Hi, my name is Lauren Massimo, and I'm an assistant professor in the School of Nursing and in neurology. I also co-direct the Penn Frontotemporal Degeneration Center, and I am the co-core leader of the Penn AI Tech ADRD Pilot Core. And today I'm going to talk about neuropsychiatric symptoms in persons with ADRD. Alzheimer's disease and related disorders, or ADRD, causes a progressive loss of memory and thinking skills. Non-cognitive symptoms are extremely common in people with ADRD. These include neuropsychiatric symptoms such as apathy, irritability, and depression, and they occur in virtually everyone with ADRD. In fact, neuropsychiatric symptoms are now increasingly being recognized as some of the earliest features of dementia. We also know that neuropsychiatric symptoms importantly contribute to poor patient and caregiver outcomes, including accelerated functional decline, impairments in daily function, early nursing home placement, and are a major contributor to caregiver burden and stress. The challenge with neuropsychiatric symptoms is that they are highly heterogeneous. They vary by type of dementia. For example, we see high frequency of hallucinations in persons with Lewy body disease and disinhibition and apathy in persons with frontotemporal degeneration. And the prevalence of depression in Alzheimer's disease is extraordinarily high. Neuropsychiatric symptoms also occur at different points in the disease. For example, we see a trajectory in Alzheimer's disease where apathy and depression can occur early on, and symptoms like delusions can appear in the later stages of the disease. Neuroimaging studies suggest that these highly complex syndromes affect a variety of frontal regions and limbic brain regions, which means that different brain networks are affected. There are also very few FDA-approved medications that are used to treat neuropsychiatric symptoms. For example, psychotropic medications may be prescribed off-label, but they come with real side effects. And while non-pharmacological interventions can be helpful, the translation of non-pharmacological interventions to the real world has been pretty limited. There's also limited understanding of mechanisms that drive neuropsychiatric symptoms, and this is an area of research that I think is a really important opportunity. More recently, the field has adopted the definition of apathy as the pathology of goal-directed behavior. Goal-directed behavior describes a set of internal processes that are translated into an observable action to attain a goal. These three processes are initiation, planning, and motivation. In order to understand the heterogeneity that we see in persons with apathy, we've studied this model of apathy to understand the different symptoms that we see in apathetic persons, and importantly, to try to explain why they might occur. We define apathy as the breakdown in three major components of goal-directed behavior, those components of initiation, planning, and motivation, and they're all tied to distinct neuroanatomical substrates in the frontal lobe. In order to engage in goal-directed behavior, these three components have to be working. Initiation is the activation of thoughts or behavior. Planning refers to mentally manipulating our goals and staying on task. And then motivation is the willingness to perform activities. So with a more refined knowledge of why apathy occurs, we can think about how we can target each one of these mechanisms. For example, initiation can be improved with external sensory cueing. And there's some evidence for this in Parkinson's disease, where these patients have lots of difficulty with initiation. External sensory cueing involves externally initiated prompts, such as auditory prompting or using visual stimulation to get the person going on an activity. In the same regard, enhancing the sensory signal by using multi-sensory stimulation can also be used to activate a person with apathy. But for people who have planning difficulty and who may already be disorganized, this additional noise may be overwhelming and may even worsen their apathy. So for people with planning impairment who have difficulty with mental manipulation of a task, it's important to think about their cognitive limitations and to prescribe their activity based on their strengths. Individuals who are disorganized may need to be in a more structured environment with cues that are provided to them in a step-by-step basis. For individuals where we want to target motivation, it's important to think about what activities are motivating for that individual. For example, for a person with frontotemporal degeneration, Food is often a good motivator. Lastly, interventions like music therapy, especially music that is live and interactive, and physical activity are good across all different types of apathy. So there's a real sense of translation from mechanism to intervention, and I see a major role for AI and technology in this space. For example, a monitoring system to track behavioral patterns to predict neuropsychiatric symptoms and their subsequent decline. Technology could also be used for delivering interventions for behavioral symptoms, perhaps in an application that can personalize and deliver interventions that I just outlined. Thanks so much for watching. If you're interested in learning more about this topic, please visit the Penn AI Tech website.